Hello, and welcome to NNJ Extra, brought to you by the Nephrology Nursing Journal, the official journal of the American Nephrology Nurses Association. NNJ Extra provides expanded content, such as interviews and discussions related to articles published in the journal and issues in nephrology nursing. The Northwest Kidney Center in Seattle, Washington, has been a leader in nephrology care for almost 60 years, opening the first hemodialysis unit in the United States in 1962. In February 2020, one of their patients was the first reported death from COVID-19 in the United States. In this episode, Dr. Beth Ulrich, editor-in-chief of the Nephrology Nursing Journal, talks with the leaders of the Northwest Kidney Centers, Dr. Suzanne Watnick, the chief medical officer, and Ms. Liz McNamara, vice president of patient care services and the chief nursing officer. They discuss dealing with the onset of COVID-19 at the Northwest Kidney Centers, how their team worked together to provide care for their patients and support for their staff members, and the lessons they learned that can benefit others. We are pleased to present Dr. Ulrich's interview with Dr. Watnick and Ms. McNamara.
Hello, and welcome to NNJ Extra. I'm Beth Ulrich, the editor-in-chief of the Nephrology Nursing Journal. Today, I'm privileged to have as my guests Liz McNamara and Suzanne Watnick, the Chief Nursing Officer and Chief Medical Officer of the Northwest Kidney Centers in Washington State, who are going to share with us their recent experiences with COVID-19. Welcome to you both.
Thank you so much, Beth.
So let's start by having you both tell us a little bit about your background and your current positions. Liz, you want to go first?
Sure. Thanks, Beth. So my name is Liz McNamara, and I became the Chief Nursing Officer here at Northwest Kidney Centers in June of 2018. I actually started nursing in 1987. I like to joke that I was 5 when I started, in case people were doing the math. I came from the hospital world, and most of my bedside years were spent in the medical ICU at a level 1 safety net trauma center. So I knew hemodialysis from the inpatient side of the house, and I was super excited and privileged to join the birthplace of hemodialysis as a part of an amazing executive leadership team. And that's where I met Dr. Watnick, my dyad partner. Suzanne?
Yeah, and I'm Suzanne Watnick, and I started in this position in January of 2017. And prior to that, I had been practicing nephrology for well over a decade. I'll just leave it at that, in the Oregon region, but had also practiced at various other areas in New Haven and San Francisco. Really was so excited to join Northwest Kidney Centers because it really aligned with some of my basic principles, were just to improve the life of people with kidney disease at both the micro and the macro level through patient care and education and research. And I was really lucky to have Liz join us because the two of us have been working really hard, no matter the challenge, including this particular situation, which really came to us first in nation.
Yeah. So walk us through how that happened. How did you experience the coronavirus and COVID-19 begin?
Yeah, thanks, Beth. This is Liz, so I'll take a first stab at that. So part of my previous role was I ran a local infection prevention and control department. So I kept in touch with folks. So we had kind of been following this whole COVID-19 thing when Washington State had its first positive patient right after the first of the year. But then, unbeknownst to us, my phone rang on Friday night, February 28th, and it was Suzanne calling me to let me know that one of our outpatient dialysis patients who had been in the hospital for a week had just died, and he had tested positive for COVID-19. Needless to say, I was shocked until I realized that, that's right, we just had our state test approved, and the CDC just opened up testing so that you didn't have to have travel history. So we were shocked initially, and then we're like, okay. So we called our local King County Public Health, who have been great partners, I have to say. We let them know that the patient was one of our patients, and we stood up. We started our Emergency Operations Command Center. We were on site Saturday morning. The particular clinic that this patient ran in was closed on Sunday, and so they do a Tuesday, Thursday, Sunday schedule along with Monday, Wednesday, Friday. So we thought we had a little bit of time. We deep cleaned the units. We were in constant communication with the King County Public Health, and we started our exposure list. So we started the list of patients that were next to the source patient. We listed all the staff that had taken care of the source patient. We furloughed all that staff, which is a recommendation that has since changed. The other complicating factor is that we provide acute care services to this particular hospital as well, and so we had a list of acute care staff that we also had to furlough. All in all, we probably furloughed around 14 staff members. So Suzanne and I really, as we worked through that Saturday, developed some guiding principles that I think have really driven us. The first being we are obligated to provide outpatient dialysis care for our patients. We knew that this was a respiratory illness transmitted primarily by droplets. We felt pretty confident in that. We knew that our hospitals were set to be overwhelmed, and we knew we could safely take care of these patients, our patients in their home units, with the right PPE. Second, we wanted to follow the science, and again, really listen to the World Health Organization. We had a very strong alliance with our local hospital partners as well. And then the third is that we knew we had to provide leadership for the community, and that needed to be transparent, it needed to be timely, it needed to be supportive. So given that third guiding principle, we actually went to the unit Sunday morning at 4:45 in the morning. I did not want patients to hear about this in the media. I had no idea when it would hit the media that this was a Northwest Kidney Center's patient. So we sat chairside with each of the patients telling them that the death actually had been one of our patients. It had happened here. We had the unit deep cleaned, although we know now that our normal cleaning protocols are fine with the virus. So that's sort of how we started. We also, huddled with the staff. The staff was fearful, of course, anxious. This was something new. We taught people how to don and doff gowns where we never had don and doff gowns before, thinking about droplet transmissions. So a lot of information really quickly. And then Sunday night, we thought we were getting things in place, and then we got the call about the second death, who was also one of our patients. So Suzanne, I don't know if you want to comment at all about those initial 24, 48 hours.
Yeah. So just as Liz described, it was quite a sprint up front. And even though this has become a marathon, it still feels like a sprint at times. But the bottom line is we worked on this together. And I think that can't be emphasized enough. I think the strength of having the nursing leader and medical leader, physician leader in any dialysis organization working closely together to make sure that not only general staff but also the physicians and other medical staff are informed in the same way is really important. So that first 48 hours, making sure that in addition to providing deep education to our patients and the staff on the facility, making sure we bring in the medical staff, informing them what we were doing, when we were doing, and why we were doing. I think the piece about the education is critical to mention. We did a number of things up front, but one of the things that was recognized within the first week was the need for very specific uniform education over the course of all of our facilities. So we have 19 facilities. All of the policies and procedures that were implemented at the one facility where the initial patient had died were implemented at all of our facilities because, as we know, COVID-19 has no bounds for rollout, so we felt that we needed to roll this out as well. In addition to all of this, we very quickly recognized that some of the challenges were not only with making sure we teach people about the science, but also to address the concerns, fear, anxiety. So Liz and I both hold calls on a regular basis. She has a daily call that initiated back really within the first week or two, and now it's turned into 2 daily calls with staff. And I do a daily call with all medical staff. And by really providing a forum for everybody to have questions answered, it has helped significantly. With that, Liz, do you want to add on some of the additional things that we've done to support the patients and the staff members?
Yeah, thank you, Suzanne. So we worked, the CDC local team landed on that Sunday, and we spent 2 weeks with them from March 1st through the 14th. We had multiple calls with the CDC team every day. We were giving them data multiple times a day. They really helped us stand up our policies. They really helped us think about when is the highest risk when we take care of the patient, given our PPE allocation, and how do we think about preserving that PPE. So that was super helpful, and they were really great. I have to say that the calls have been crucial. Staff feel heard. Staff like getting the updates, and so we start our calls with what are the local numbers, what are the hospital numbers. We talk about how many patients of ours have been tested, how many are positive. We talk about how many staff have been tested and how many are positive. So just giving people that information really helps. We have a staff person who worked in New Orleans and said, one of the things that they did during Hurricane Katrina was help the staff get things that they weren't able to get, supplies. So It's going to sound tongue-in-cheek, and I know it's kind of a joke, but we source toilet paper that we put in the break rooms for people to be able to take home with them. We have hand gel. We actually worked with a compounding pharmacy to make hand gel. Give that to our staff. Give that to our transportation people because they're key in all of this as well. We made Northwest Kidney Center colored bandanas, knowing that in a mask shortage situation, we could give those kind of things to our patients who are outside the clinic, to the transportation drivers who are outside the clinic. So any little thing that we can do, we tried to do to the staff so that they felt appreciated, knowing that it wasn't just them, but it was their families who were helping support them being able to come to work. And I think the partnership with the physicians can't be spoken to enough. This isn't a dialysis disease, right? We don't need dialysis-specific acumen, but this is an operational disease, and it takes both of us together to be a united front, and that's really powerful. Even from the hospital world, nurses can't change things themselves, and neither can docs, but man, we are incredibly powerful when we work together. Those are some of the highlights. I will say that one of the biggest challenges to the staff anxiety is the media. We talked to a local newspaper, and I said that's our biggest challenge because you can't get away from it. And so we've really tried to message to our staff, get away from it. Don't watch the news tonight, right? Play a game. Do something different. Take a walk because this is going to take us a long time, and this is going to change the way we practice. One of the other things that I think too, and Suzanne and I have also talked about this, is a lot of the things that we've implemented are things that in an ongoing way are just going to benefit dialysis. Thinking about how we approach flu season in the future, thinking about using modified contact droplets, thinking about masking, it's just best practice. We also implemented routine cleaning of all of our shared surfaces, wheelchair handles, rails of the scales, common areas, both for staff and for patients. Those are things that we won't just drop off when we have a lull in the COVID-19. Suzanne?
Yeah, so it's really important to think about all of those additional items that, I hate to say it, but sometimes a crisis allows for opportunities to be innovative and implement something more rapidly than you might otherwise. I think in addition to all of the additional infection prevention and control interventions, we've seen a number of waivers from Medicare on the 1135 waiver abilities and items such as telehealth waivers, so allowing our physicians and other medical staff to be able to have more frequent interventions and interactions with the patients, I think is an important thing that we're in the process of implementing right now. In addition to this, we haven't talked too much yet about the home dialysis environment, but we've rolled out all of our screening for patients as well as screening for staff in the home environment too. We've even thought about, hey, these patients specifically are home dialysis patients. They want to be home. How can we provide additional quick visits? And there have been great ideas throughout the entire country, things such as drive-through testing. But, for us, we're able to implement some rapid visits, what we're calling quick visits, so that patients can come very expeditiously to get their blood drawn as well as gather supplies, and then be able to have interaction via telehealth with the facilities. So as difficult as this has been, as challenging a time as this has been, there are some items that we're able to implement to benefit our patients that hopefully will stay there and that we'll be able to partner with the various national groups such as CMS to allow some of these regulations to persist afterwards.
Yeah, I agree.
So I, like you, have a bias towards home dialysis since you all started home dialysis, and it was the first job I ever had in nephrology nursing was to open a home dialysis center. So long term, I'm wondering, do you all think this could have an influence, this whole pandemic could have an influence on more patients wanting to go home or organizations more willing and facile at sending them home?
I think there's no question that it will have an impact. As folks are aware, this summer the Advancing American Kidney Health Initiative was put forth.
Right.
And many dialysis organizations are aiming, 25%, even 50% as a goal long term. And I think that for so many reasons, a number of people around the country have not been able to consider home dialysis to the same degree that they might be able to in different environments, but I think that this in particular are going to help patients to consider very strongly what the best option is for them, dialyze at home or dialyze not in their home. So I do think that it's going to impact this, and that's part of the national conversation right now. Most of the dialysis organizations do feel that this will have a positive impact in getting a higher number of patients to do home dialysis.
Yes, I agree with you, and I also think that hasn't changed our message for the NKC because we have always been really pro-home.
Exactly.
So I think it may, but I think it's just doing more of the same, and I think having these telehealth visits is just going to help us make it that much more easy for patients and their families.
So, Liz, you had said a little bit about education. I mean, you all know how to dialyze patients. Your staff knows how to dialyze patients, but not deal with a pandemic. Mm-hmm. What kind of things did you do to educate the staff, the medical staff, the nursing staff, the care technicians, to get them going on this with obviously no notice when you started?
Yeah, so a lot of it wasn't written down at first. We had all of our policies actually stood up within a week, I was shocked, but we made a video on how to put on a gown and how to take off a gown, and so we launched that. We actually did just-in-time physical donning and doffing demos at every clinic, and so I took my core group of clinical directors and showed them how to do it, and then they went out and they showed other people how to do it. And so we had a checklist. We have an infection control nurse as well who was key, being out there talking both to the patients and to the staff, and so that was a huge help. We used the CDC donning and doffing because there's no reason to reinvent the wheel, and so we really wanted to use what was out there. We also used hospital partners' infectious disease expertise as well, and so whenever they would write something, we would share that with our staff so that they didn't think that it was just us sitting here making this stuff up, right? Because that's what it can feel like sometimes. So we really wanted to use the science and use the expertise. We're incredibly fortunate here in this city. We're a little bit the birthplace of infectious disease as well. So we have a lot of expertise that we were able to draw from, and I think from the physician side as well. I think it was helpful for the physicians to also hear from other expert physicians, and knowing that Suzanne and I were saying pretty much the same thing to whichever group we were talking to was very reassuring, I think, to the staff.
Yeah, I just have to second that. Not only were we able to do this in the local region, but this was a definite partnership with our public health partners, the entire community here, as well as the national community. You know, we're a nonprofit, and we've been working really closely with a number of other nonprofit dialysis organizations to try to come up with best practice. We're not doing this in a vacuum. We're trying to work with CDC, with the WHO principles. And so I think it really is important so that people do understand that even though this is an evolving situation, and things are changing sometimes week to week, we're doing this as we learn to try to follow best practice. And I think that's a really important message because it's not just the what, it's the why. And I think both staff, patients, and all of the medical staff involved really can understand and work with us together if they understand that why. Again, leaning back on those three main principles: providing dialysis, leaning into the science, and making sure we're providing appropriate leadership through this communication and transparency and support. It's really seeming to pay off for us.
So you all talked about supporting patients and staff. Tell us what you did specifically to support your patients and then also to support your staff, mentally, physically, psychologically. What kind of programs did you guys put in place, or what did you do?
I think for the patients, it was transparent communication. We have probably 4 versions of a patient letter that we sent to all patients, being honest about what they could do to keep themselves healthy. We adapted our online website so it's very clear, COVID-19, and I think what we told them is first and foremost, you need to come to dialysis. So our registered dietitians have put together some tip sheets for them because we don't want our patients going and just stocking up on all these canned goods, right? And what goods can they have at home? Our social workers normally call patients that miss their treatments, but we have a new focus of that, reassuring them that it's safe to come to dialysis. So it took the whole IDT team, I think, and it's an ongoing conversation. For the staff, again, I think it's the multiple times a day, daily phone calls. I think it's the ability for them to know that we're there. We want to balance being visible and not burdening them in the unit, and so we think about how we round and how often we round physically. In the units we talked about, we provided a child care stipend for people that need help with that because a lot of our staff have a lot of kids. And those have been the main things that we've done. Suzanne, is there anything I missed?
No, I think, again, we talked about the forums that we've been providing. And to be honest, I think that that's probably the most valuable thing that we've done. And I have a feeling that given how much success we've felt with that, that may be something that's long lasting for the organization, perhaps if it's even just once or twice a month to have open forums like that. But really the support for patients and staff, it's the communication that we've been providing. We didn't mention that we're actually crafting a communication for the entire NKC community, both internal Northwest Kidney Center staff as well as medical staff, that goes out every morning, updates. So it's not just the calls, but it's written communication that I think has really been helpful.
I also saw on your website that you've established a COVID-19 emergency response fund for your patients and staff.
Yeah, we have. We had a huge outpouring from folks saying, what can we do to help? So it's been really nice because we're not completely sure, but we know we're going to need some help. People have wanted to do the hand-sewn masks, and so we're actually accepting those, but we're giving those to the patients who are outside the clinic. We really want our patients to have a medical-grade mask while they're here with us. So it has been nice. In fact, one of our probably more outlying clinics drove into work the other day with a hand-painted sign that was put in their yard that said, "Thank you so much, healthcare workers, NKC." That was really heartwarming. Because, a lot of the press is in the ICUs and in acute care and things like that. But we feel that if we weren't doing our part, that it would really hinder our hospital partners. And so we know that we're making a difference that way.
It occurs to me that one of the questions I didn't ask you early, and probably some of our listeners don't know, is tell us how many patients and about how many staff you have at NKC total.
So we currently have a little over 1,850 patients. Approximately 270 of them are on home dialysis, between peritoneal dialysis and home hemodialysis. And we have on the order of just under 800 staff members. We have over 100 medical staff members. Of that, about 40 plus of them are active medical staff. So we really have a lot of folks that we try to interact with, and it's always a challenge to make sure you're getting the right message to the right people at the right time. And not everybody is going to see all of the initiatives that we're taking as necessarily the right ones, but nonetheless, we're open to feedback. And so not only do we announce and communicate, but we also have been really taking the feedback at the level of our emergency operations center so that we can hear what's going on and to potentially change what we're doing to make sure we're doing the best we can for our patients and our staff. That's the point.
Yeah, I think the only other thing is that we have our EOC, Emergency Operations Center meeting. We still have that daily. For the first 2 weeks, we had it twice a day, and now we still have that daily, and I think we're launching week 6 of our response.
So, Suzanne, you had mentioned earlier the strong working relationship that you and Liz had. How did that come to be? Because that's obviously helped you succeed in this and be pretty quick and agile in your responses. How did you guys make that happen?
So there's no easy, simple answer to that, aside from the fact that, first of all, Liz is wonderful. So that goes without saying. She brings tremendous strength from a nursing leadership perspective. And I think both of us have worked very hard to make sure that we're doing what we can to work together. I think a very defining moment was a little less than a year into Liz's tenure here as Chief Nursing Officer. We joined together to attend a Chief Nursing Officer and Chief Medical Officer meeting, national meeting, and it was interesting. The two of us were the only two initially to sit together at the same table. We also, it was, we rented our car together, ended up getting a little convertible and took it out to where we're doing, really partnering, talking about what we're doing. We talk about it as a Thelma and Louise moment to some degree, although I think we have had better outcomes than that particular movie.
So far.
Yeah, you can go with it, right?
Right. So, I'm certainly very glass half full. That's the kind of person I am, and I think that our collaboration not only has been incredibly powerful as leaders, and we don't always succeed, and we point out, look, even the two of us missed something, but for the most part, we're really on point together. And I think it's important for folks in the organization to see the nursing and the physician components of the organization come together closely. Liz, what else do you want to add to that?
Well, that's good. You gave us away, Thelma and Louise. I think the only thing that I would add to that is that we've been doing this intentionally. And so we've actually been partnering with NTDS to grow leadership within the dialysis world. And so we actually had a full day conference education session with our dyad partners of our nurse managers and our medical directors of each of the clinics. We did some leadership work. They took some tests. It was a great day. And in fact, we're going to launch a WebEx. Gosh, it was supposed to be, I think, next week. That, of course, has been pushed back. But we've really taken a very methodical approach to this work, because learning how to lead, knowing how to lead is just as important as knowing how to order dialysis or put needles in or run a machine. And it's that piece of work that sometimes gets missed, both in our nursing and our physician training. So we're just kind of a case in point of what we've been trying to accomplish.
Well, it's good to see. So based on y'all's experience, what advice would you have for other dialysis centers in general and nephrology nurses in particular, based on what you've learned?
I'll start off really briefly, and I'd love Liz to finish this up. I'm going to go back to the 3 basic principles. So if you're talking about what do we think about, first and foremost, we should be providing dialysis. We have an obligation to provide dialysis for our patients in the safest and most effective way that we can. Secondly, we should be doing the best we can to use the understanding, the science behind what's going on to make sure we're providing the right kind of treatment for the right patients at the right time. And then lastly, the leadership piece that we both alluded to in your prior question, making sure that we're providing that with appropriate communication, lots of transparency, and really support at every level so that people can hear us and have the opportunity to give us feedback. And with that, making sure that patients and staff understand that we're the humblest of their servants to try to do this well. Liz, what would you like to please add to that?
Yeah, no, I think that's exactly right, Suzanne. And I can't say enough of that. This is a marathon. This is long term. We have to take steps away. We have to take a break, even if it's an hour, to walk your dog, or as I say jokingly to people, walk my dog. I sent an email to my staff, actually, when we got some feedback that was a little bit hard to hear about how our staff was feeling, and it came from outside the nursing world. And as I noodled about that, I realized that, it's not about where we hear the feedback from. It's not about not listening to it, but we have to attend to it. We have to hear it, as hard as it is, because that helps us do the right thing for both our patients and our staff. And I ended that email with this quote by Winston Churchill, and it said, "Success is not final, failure is not fatal. It is the courage to continue that counts." And I really think that speaks to our times right now.
That's a great quote. So how are things going now? You're 6 weeks in, you said?
Yes, we are. But you know what? The nice thing about where we are now is that we never get bored. And there's something new every day. There really is. And I think the important thing to give advice to folks who are listening here is to make sure that you're taking care of yourself. Self-care is really important. Along Liz's comments about this is a marathon, not a sprint, we need to be resilient. We need to be resilient for our patients and for our staff. And there is going to be something new every day. So whatever you can do to take care of yourself so that you can come to work ready, mildly refreshed, to be able to carry through as we move through probably the next month or two.
Yeah, absolutely.
Any other final thoughts, Liz?
I'm so appreciative of the partnership and the ability to chat with the ANNA community. When we first heard that there were guidelines around airborne isolation, I picked up the phone and I called Jamie, and she called me right back, and we had a joint meeting. So it's been great seeing the ASN WebExes spill over into the nursing world as well, so we can all join together and hear the same information. I think when we come out of this, at least to get a little bit of a breather, we're going to be much better off, and our patients are going to be much better off. So I'm just so thankful that we had the opportunity to share with folks our experience. And I look forward to being able to hear from others once the dust settles as well.
Well, I want to thank you both for taking the time to share your experiences and your valuable insights with us. Just as the Northwest Kidney Center was a leader at the beginning of nephrology care, being the first chronic hemodialysis unit in the United States almost 60 years ago, your leadership and experience clearly continues as we face this. Thank you very much.
Thank you, Beth.
Thanks, guys. That was great. You guys take care. Stay safe, okay?
All right.
You too.
Bye-bye.
Bye.
Bye.
NNJ Extra is brought to you by the Nephrology Nursing Journal, the official journal of the American Nephrology Nurses Association, and is owned and produced by the American Nephrology Nurses Association. All rights reserved. No portion of this podcast may be used without written permission. Dr. Suzanne Watnick is a professor in the Division of Nephrology and the Chief Medical Officer at Northwest Kidney Centers at the University of Washington in Seattle, Washington. Ms. Liz McNamara is the Vice President of Patient Care Services and the Chief Nursing Officer at the Northwest Kidney Centers at the University of Washington in Seattle, Washington. Dr. Beth Ulrich is a professor at the Cizik School of Nursing at the University of Texas Health Science Center at Houston and the editor-in-chief of the Nephrology Nursing Journal and a past president of the American Nephrology Nurses Association. For archived episodes of NNJ Extra and to learn more about the American Nephrology Nurses Association and the Nephrology Nursing Journal, visit annanurse.org. You can also subscribe to this podcast on Apple Podcasts, Google Podcasts, Spotify, Stitcher, TuneIn Radio, our hosting site Spreaker, and everywhere podcasts are found.